Everyone. This is our webinar this evening presented by Allara Health and Blooming Eve Fertility on fertility and infertility 101. Thank you very much, everybody, for joining us tonight. For our webinar this evening, we have two experts who will be speaking to you. Dr. Stacy Hennigsman is our medical director at Allara Health. She is an OBGYN, and she will be speaking to us on the process of defining fertility and infertility and how we can help to prepare for fertility and the type of testing that needs to be done to help somebody understand their fertility journey ahead of time. And then Dr. Joshua Klein is the medical advisor at Blooming Eve, and he's going to be speaking to us about more of the process around egg freezing and fertility care with a reproductive endocrinologist. So I'm going to allow both of our experts tonight to introduce themselves to you and give just a little bit of a bio about themselves. And Dr. Hennigsman, I'll let you get started with that. If you can share with us just a little bit about yourself and your practice and your work here at Allara.
Yeah, Danielle, thank you so much for inviting me to speak. So as Danielle said, I'm Dr. Stacy Hennigsman, the medical director of Allara. I've been in practice as a general OBGYN for 20 years, and I've been working for Allara for around 2.5 years. And we're a telemedicine platform that treats chronic women's health. So we treat PCOS, endometriosis, fibroids, hypothyroidism, kind of the full gamut.
Thank you so much, Dr. Hennigsman. We are extremely lucky to have you as our medical director here. And Dr. Joshua Klein, medical advisor at Blooming Eve, if you'd like to give us a little bit of an intro of yourself. And also, if you don't mind, tell us a little bit about Blooming Eve as well for folks who maybe have not heard of your clinic before.
Yep. So thanks for inviting me to join. So I am Dr. Klein. I'm a reproductive endocrinologist, which is basically a fertility specialist. I have been doing fertility for a little over a decade. I co-founded this place called Extend Fertility in New York City, which is my day job, in 2015. And we are a full service fertility clinic, meaning we do all sorts of fertility treatments like IVF and IUI, but we also have a very sort of special focus on fertility preservation and egg freezing, which is a very particular interest of mine. I actually joined Blooming Eve as a medical advisor just a few months ago, so I'm new to the Blooming Eve team. Blooming Eve is a new company that is basically positioning itself as a sort of fertility navigation platform, because it can certainly be very, I think, daunting for people to try to figure out where to start and where to go when it comes to understanding the journey that it can take to go from someone who's understanding their fertility to actually pursuing fertility treatment, whether it's egg freezing or IVF and other fertility treatments. And so Blooming Eve sort of is a repository, a database that integrates information about clinics, both like basic stuff like demographics, but also things like pricing, reviews, success rates, and sort of can act to some degree a little bit of a, maybe, I don't know, the company will speak for itself, I guess, but maybe like Expedia or one of those sort of places to integrate all sorts of information to help guide the journey. And so that's Blooming Eve. You can find out more from someone who does it as their full-time thing, but I think that's probably a good summary for everybody.
Fantastic. Yeah, thank you for sharing that. What an interesting platform, from what I've learned a little bit about Blooming Eve in our kind of increasingly, digital world, where it's very hard to know what are trustworthy platforms. I know this is a question that comes up a lot at Allara, is how do we know who really knows what they're doing kind of in this very confusing space of reproductive and metabolic health. So it's really wonderful, and we are especially very lucky to have partners like you that is just so educated about this and bringing a new type of aggregator to the world and to our patients that really helps people to find what the right services are for them. So really interesting. And if anybody on here needs to check out Blooming Eve, we will have links to do that at the end. Okay, let's get into our topics tonight. So we have a couple of top kind of main idea topics, and most of these are kind of first 25 minutes is going to be spent on addressing kind of big topics that you folks sent in ahead of time for questions. And then for the last 30 minutes, stick around because Dr. Klein and Dr. Henningsman will do an open forum Q&A for you to ask any questions that may be specific to you and that you would like a little bit more clarity on. So all questions are welcome, and we will start that at in about 25 minutes. But first, let's get to our main kind of educational portion of this webinar. Dr. Henningsman, I'm going to start with you. Can you please start by defining infertility for our listeners tonight?
Yeah, absolutely. So we define infertility as a failure to achieve pregnancy within 12 months of unprotected intercourse in women younger than 35, or within 6 months of unprotected intercourse in women older than 35. And infertility actually affects up to 15% of couples. And we can usually offer an infertility evaluation. A lot of people want to know, well, when do I, start looking for an infertility evaluation? And really, we can offer it to anybody who's been diagnosed with infertility or is at a high risk of infertility. So if they have certain conditions such as PCOS, we're going to offer them an infertility evaluation a little bit sooner than the 12 or 6 months.
Mm-hmm. Okay, great.
Yeah, I would just piggyback on that for a moment and just say that that's definitely sort of the guidelines that most of the reproductive endocrinologists would also kind of follow. But these are guidelines, not strict laws. And so, for example, there are women or couples who would come into my office who have been trying for less than those guidelines, but they say, look, I want to have at least 3 kids and I'm already in my late 30s and I'm worried that I need to be kind of very proactive. And so at a minimum, I want to just do testing to rule out any problems, even though technically I haven't met criteria. And, that's something that technically there's nothing wrong with doing that. And so there is that personalization of what the patient's goals are for family size, how old they are now, and what their mindset is with regard to how aggressive or how passive they want to be. So, like any guidelines, I guess it certainly sets the stage, but that doesn't mean that that's necessarily going to be exactly what's right in your case. And then the other thing which Dr. Henningsman just said is that, someone, let's say, who has a known condition like PCOS, for example, or even making it even simpler, if you know that you don't have regular menstrual cycles, right? So it probably wouldn't be a helpful thing to say, oh, go try for a year and then come back if you never get a period, right? That's probably not gonna be a productive year. So again, point being basically that there are guidelines and then there's individualization for your particular story.
Yeah, and exactly. And if someone comes to me and says, I want to do oocyte cryopreservation, I want to freeze my eggs, then I'm not going to sit there and say, oh, well, you need to wait. I'm going to send them right away. So yeah, it totally is dependent on the patient in front of you. So we're going to definitely start a workup if we find something that is a little more concerning to us. Absolutely.
Great, thank you. And I think you both really touch on a maybe almost an intangible topic that I know so many of our patient population between both of our organizations face, which is that emotional thing of, knowing that there is something that the patient wants so much and being told that there is a timeline that they have to be in, and it's you haven't done it long enough or you haven't waited long enough. And I think that's something I know here at Allara, because this is where I see most of our patient population. But I know it's something we take so seriously, is making sure we're listening to what those patient goals are to help them know, we have just more information.
Yeah, and we have a very low threshold or referring out or any type of reproductive endocrinologist if they want to see someone. So yeah, absolutely.
Mm-hmm. Okay. So Dr. Einigsman, you kind of left off on this a little bit on the workup that we might do maybe before a reproductive endocrinologist would maybe have a referral for that. Tell us a little bit about some of the first steps of knowing if there are fertility issues and what you might do to help somebody understand more about their fertility.
Yeah, so we first have to look at a couple of things. So we're going to look at first ovulatory function. So we have to see, are these women ovulating? So we're going to do that by looking at regular periods. We can do a progesterone level in the luteal phase to confirm ovulation. And we're also going to look at ovarian reserve, which I'm sure Dr. Klein is going to speak of. But we can do an AMH level. We can do a day 3 FSH and estradiol level. We can send them for an natural follicle count ultrasound. So we're going to do those things. And then we also have to look at structural abnormalities. So we have to make sure that their tubes are open, make sure they don't have any fibroids, polyps, anything like that. And then we're also going to look at the male factor as well. So we're going to send their partner for a semen analysis, or we're going to send the partner to reproductive endocrinologist to do the semen analysis. So we're going to do just kind of the basic workup. And then if we find anything at all going on, we're likely going to refer out to a reproductive endocrinologist. So that's just the basic, 5-minute workup on a telemedicine platform that I can explain. Yeah, those are the basic things. We have to make sure they're ovulating, they're ovarian reserve, if there's any structural abnormalities, and also we're going to look at the male factor as well.
Great. Dr. Klein, would you like to add anything onto that on what you might then from your side when we do refer to you?
Well, surprisingly or not, that's actually a great summary. And, I'd even crystallize it down with my patients into a simpler version, which is basically, we need eggs to make a baby. You need eggs, you need sperm, and you need plumbing. Eggs obviously are a necessary ingredient. And you need to have healthy eggs, you need to have enough eggs, they need to be released on a regular basis at the right time. So there's more layers there, but that's kind of that bucket. And what Dr. Huntington said is exactly right. We want to make sure by checking ovarian reserve, by checking ovulation, those are sort of the primary factors that we're looking at. Sperm is pretty straightforward, well, at least on the most basic level in terms of doing a semen analysis and getting a sense of what the status of how many sperm, how healthy they are. Of course, there's more layers of complexity depending on the details. And then for a natural pregnancy to occur, or some basically other than IVF pregnancy to occur, you need the mechanical venue for the eggs and sperm to be able to find each other, which means you need to have a healthy cervix, uterus, and fallopian tubes. And so you really cover the vast majority of what we think about, even within the realm of the specialty of it in a fertility clinic, with that short list. Everything else is kind of just details. And again, there are some details, but that really is like the quick and dirty full fertility workup to give us enough information to think about, okay, if we want to push this person in the right direction, what type of treatments would be appropriate to be considering.
Perfect. Thank you very much. Okay, so now kind of getting into a little bit about maybe factors that are affecting someone's fertility, like you both have so eloquently explained so far. Are there any ways that some women or folks who are thinking about conceiving that maybe have PCOS or endometriosis, or maybe even just, infertility struggles, what are some of the ways that we might look at to help improve fertility for these individuals?
Yep.
Go ahead, Dr. Klein, sorry.
Oh, no, either. But I would say, sort of big top line things to have in mind. So it's important to emphasize, I think, that there's no magic bullets. Unfortunately, there's a lot on the internet and on blogs and whatever of, this supplement and this food, and that there's shortcuts or these sort of boosters that can really be, supercharge your fertility. That's probably a tagline on some product, at least more than one probably. But for the most part, those things are not usually scientifically evidence-based, as we would say. I think the summary is generally that healthy lifestyle, healthy habits, general health supports fertility health, right? In a certain way, from an evolutionary standpoint, humans are programmed to be able to procreate when we're in generally good health. If someone is very overweight or very underweight or sick in some other way, whether it's physical health or mental health, the body has fail safes to sort of say, this may not be the best time to be getting pregnant and having children. And so that can, in ways that are sometimes conscious, but sometimes not, put a fly in the ointment as far as the proper reproductive function. So I think the basic message is kind of boring, but it's true, which is that the best way you can prepare for starting a family when you're ready to start a family is to just maintain your overall health in the ways that you probably already familiar with. And I, wouldn't sort of be speak as an expert on those, but lifestyle stuff, diet, exercise, stress management, all those kind of things. So that's really my main answer to that big question. Dr. Henningsman, I don't know if you look at it differently or kind of the same.
No, I look at it the same, and I look at more because I deliver the patients and follow them through their whole pregnancy. And so I'm looking at decreasing obesity, because obesity and unhealthy lifestyles are going to predispose a patient to gestational diabetes, chronic hypertension, preeclampsia. The C-section rates are going to go up, even things like stillbirth and spontaneous abortion. So yeah, really just to very healthy, get the weight, the BMI under a good range. We like it less than 30. And again, low weight is also just as bad as obesity. So exercising, eating properly is really what we like to say for a healthy pregnancy.
Mm-hmm. Yeah. And, Dr. Henningsman, I know that I love that Dr. Klein kind of touched on some of the myths that are out there on, maybe we see things on TikTok or social media. Sometimes we joke about those maybe internally that maybe people see about improving their fertility. But Dr. Henningsman, can you tell us maybe just a couple of, maybe how we at Allara as kind of first line fertility care might use more evidence-based methods to help patients improve their nutrition and their lifestyle?
Yeah, so we really do follow evidence-based, guidelines. So we're going to recommend 150 minutes to 300 minutes a week of moderate exercise. We have registered dietitians that they're going to meet with, which is really basically half of our program. A lot of patients don't have access to registered dietitians. And so we as medical providers don't get a whole lot of training in medical school on this. And so what's so special about Allara is half of our program is the registered dietitian. So you're going to meet with a medical provider plus a registered dietitian, and they're going to go over your diet, your exercise, any kind of supplements, those types of things to get you in the best health possible before trying to conceive.
Mm-hmm. Thank you so much. All right, Dr. Klein, I'm going to pass it now over to you to kind of dive in a little bit further into the egg freezing process and the heart of all of this. So if you'd like to maybe just start by telling us what is the egg freezing process?
Yeah, I'll actually take even 2 steps back before that. The way that I got interested in egg freezing as, again, a heavy focus of what I do every day is basically because, we spoke a few minutes ago about identifiable obstacles to fertility. If there's a low sperm count, if the fallopian tubes are not healthy, and so on and so forth. But the sort of background element that's ever present is that for anyone to be able to get pregnant, as we said in the very beginning, you need the availability of healthy eggs. And age is our biggest enemy in that conversation, because it is the natural process that women are born with their eggs for their lifetime. And as they get older, 2 things, in a negative way, 2 things happen to their eggs. Number 1 is the quality of the eggs decreases, and number 2 is the quantity of the eggs decreases. Egg quantity is the simpler concept in a certain way. And what I mean by that is that basically you're born with a lifetime supply, and every day eggs are dying off, and eventually every woman has none left. And there's a name for that, which is called menopause. The reason why menopause is a concept, and it's a universal concept, is because every woman eventually will run out of eggs during her reproductive lifetime, and so one part of the story is that there is this finite supply of eggs that ultimately will run out. And in parallel with that, you also have this concept of egg quality, which is the health of the eggs. And I think this one is more frequently misunderstood because I think most people imagine egg quality, that the eggs are like produce, where they start out like young and fresh and strong, and that they're sort of spoiling in slow motion, that every day they're getting like a little softer, a little bit more wrinkled, and that all the eggs are getting incrementally worse every day. But really, a more accurate way of thinking about it is that some eggs are normal, genetically intact, and some eggs are abnormal, genetically broken. And basically, the way the system works is that when a woman is born, all of her eggs are genetically normal. But every day, some eggs are having a breakage in a chromosome. Chromosomes are pieces of DNA that leads to either a gain or a loss of DNA. And that particular egg that's had that happen now goes from the normal team to the abnormal team. And so when we say that egg quality changes as a woman gets older, what that really refers to is the proportion or the percentage of the eggs that are normal versus abnormal is what's changing. So a woman in her 20s, for example, has something like 90% of her eggs are still normal and maybe only 10% are abnormal. The abnormal ones are totally bad, but the vast majority are still totally good. A woman in her 40s may be the opposite. 80 or 90% might be bad, although 10 or 20% are still good. And by the way, that's why it's not impossible to have healthy pregnancies in your 40s. It's just more difficult because it's harder to find those healthy eggs when they're representing only a small minority. So those are the basic kind of gears in the machine of how age affects fertility. And to sort of add one thing or layer one more thing onto that is that egg quality is universal. There aren't really exceptions in major ways anyway to age. Everybody in their 20s has mostly healthy eggs, even if they're not super healthy people. Everybody in their 40s has mostly unhealthy eggs, even if they are super healthy people. Whereas egg quantity is not universal. So you can be someone in your 20s with a lower than average egg supply, and you can be someone in your 40s with a higher than average egg supply. And conveniently, that's something that can be tested and can be identified. So with that sort of background being said, for a woman who is in her, let's say, late 20s or 30s or even 40s, who isn't yet in a position that she wants to start a family or is able to start a family, but she knows that time is not her friend, right? And that she doesn't know when she'll be ready to start a family, but she's worried, or at least trying to be proactive about the fact that she might be ready to have her, whether it's her first child or maybe it's going to be a second or a third child, but that's going to be at some later date when she might be old enough that it might not be so easy to conceive. So you can make a proactive choice to take some of your younger eggs today and have them removed, as I can explain, and then sort of put aside, frozen, literally frozen in liquid nitrogen, such that if you freeze your eggs when you're 30 and then you want to have a baby when you're 40, you actually have the sort of potential to, or the success rate by and large, of a 30-year-old when you're 40. It's like you're donating eggs to your future self. That's the concept of egg freezing. And so that's why it can be a helpful strategy with regard to planning a family. I'm kind of throwing out a lot of concepts here, and we might have to, kind of review some of them or pull them together again. But the bottom line is that when it comes to egg freezing, there is some information that can be individualized, which is to say, we know your age, of course, but we don't know your egg supply without testing it. It's relatively easy to test. Dr. Henningsman mentioned a few minutes ago, AMH is probably the single simplest, best test. It's just a blood test. It's pretty easy to find. And by knowing someone's age and their egg supply, we can have a pretty good sense of if egg freezing would be a valuable option for them to consider. And then ultimately, of course, it's a personal choice if it's something that they want to invest time and effort and money in doing.
Okay.
I guess I didn't talk about the process, but I don't want to keep.
Well,
I
guess.
A lot of it is knowing the conceptual background. I think the process is almost like it's important too, but the first step is to really understand why it might make sense to do it or why it may not be worthwhile. And by the way, it can be, I see women every day who are thinking about egg freezing, and not everybody decides to go ahead, and that's a healthy thing. I think that not every patient walks in the door actually decides to go ahead with it. And of course, there are different scenarios, right? If a woman is 44 and has a very low egg supply, so the reality is that if she does freeze eggs, she's probably going to get a small number of eggs, and most of the eggs we're going to get are not healthy. And so the potential value of those small group of frozen eggs may be very low. And so that doesn't mean she can't do it, but that might mean it's not worth it for her to consider doing it. Or the opposite, if a woman walks in and she's, in her 20s and has a very high AMH, and she's sort of in a very good prognostic category, yeah, she could freeze eggs and she would probably get a lot of eggs and a lot of healthy eggs, and that there's no reason that she couldn't. But she may say, you know what, I might give it a couple of years because I'm only in my 20s and I have a good egg supply and actually everything is checking out okay. So I don't feel like I have to run to freeze my eggs today, and that's okay too. So it's a tricky discussion because there are a lot of factors that can play into why it might be a good idea or not, and that's the kind of stuff that we talk about every day.
Yeah, and I mean, I think that a lot of my patients, come in and they're like, when do I freeze my eggs? Should I freeze my eggs? And I mean, and even if they're 25, which is awesome, that's when I'm like, please go freeze your eggs. I'm going to refer them right away to a reproductive endocrinologist, because I think all women really need to have this conversation if they're even thinking about it. And so I will refer out to someone like Dr. Klein to give them all of that information so they can make the best possible choice for themselves. Absolutely.
Yeah, I think you both really made some great points here, is that there is very little, and I know this is why Blooming Eve exists, is to really help patients to try and get the right information and get the right specialists, get in front of the right specialists. And it's, so important to us here at Allara as well. And it's why we have Dr. Henningsman as our director, who's so invested in educating patients about what all of this really means. And it's been so, I think, in the dark for people for so long. And I know neither of our experts here want to scare anybody or make you feel like you've done the wrong thing. This is really just about making sure that you're armed with education, that you're armed with the information so that you can make really good decisions about your health, and that you have experts that are here to help you, to guide you along, kind of making these choices that are, that are big deal.
Yeah, and I mean, I think that's super important because you see so much stuff on social media and influencers and everything. So I think it's just really important to talk to your OBGYN, and your OBGYN can get you to the right specialist. So I think that's probably a really good takeaway I want to have everybody understand, is just talk to your medical provider about it, and we can get to where you need to be. It doesn't have to be scary or confusing. We can figure all that out.
Yeah. One other thing, which is, I guess, loosely related to this, is that what some of this is also echoing is the idea that, when people are looking for the right doctor, let's say, so a lot of people are sort of very focused on, who has the best success rates and statistics, and that's all obviously very important stuff. But I think it's important to emphasize that, number one, someone who's trying to get pregnant, not everybody who has infertility issues even needs IVF at all, right? If there's a clinic that every single patient who walks in the door is doing IVF, that's not a good clinic, because that doesn't make sense. Not every patient is going to need IVF. And to be very direct, there are some doctors who are more eager to do IVF sooner, and some doctors who will be a little bit more individualizing when it comes to the care plan. And so, I think that a big piece of, quote unquote, the right provider is someone who is going to be willing to take the time to understand the details of the situation, the details of your goals and of your mindset, as far as, again, how patient you want to be or not, what are your biggest fears and what are your biggest, kind of priorities. Because even with the same kind of bare minimum facts from a biological or medical perspective, one patient might go straight to IVF and another patient might spend the next 3 or 6 months doing, some pills, IUI, lower level treatments. And that doesn't mean one is wrong and one is right. It means that the right answer, even with the same facts, is going to be different for different patients. And so I think that that's an important piece to keep in mind, is that if you are looking at how do I find the right kind of doctor, or if you've spoken to a doctor, even if you're feeling like someone talks to you as a person and listens to you as a person, that's a good sign. And if you're feeling like, you're part of a big part of their statistics, that's a little bit more worrisome. Again, statistics aren't inherently evil; they're important too. But I think that this is an area of medicine for which individualization of care is not only an ideal, but I think it's a necessary element of good care, because you're just not going to have the same answer for every couple or every patient, even with similar kind of facts.
Definitely. No, for sure. And the non one size fits all model is what we all really aim for with all of the, our entire population, is making sure that the the person feels just heard, and that they are supported to make good decisions and really know what their own body needs, because it really is so different for everybody, even though there are some of these high level facts. But everybody, that's any of you who are listening right now, this is all going to be different for each of you. Just as long as you have the good information and you know where to get it, then you're gonna be okay. Right?
Agreed.
Absolutely.
All right. So we are just at about 30 minutes. We can start with the Q&A, unless either of you, Dr. Klein or Dr. Henningsman, has anything else that you want to discuss, but we can start with a little bit of a Q&A portion, and I'm sure some things will come out through the Q&A that we may repeat and just kind of drive home for you, and maybe some new things will come out. So what I will do here is you can put in the chat. If you are shy to speak up, you can put your questions in the chat, but I will also, or if you want to ask a question and you want to kind of raise your virtual hand, I can unmute you and you can ask a question directly to the doctors. Why don't we start with that? Who's going to be brave and ask a question? We got questions that were submitted ahead of time, so I can go through those if no one wants to ask anything. Okay. All right. Let's see. Let's go to a question that was submitted. Okay. I think we have covered a good portion of questions that were submitted, but I'll just kick it off with a question that was submitted ahead of time. So kind of getting in a little bit more specifically, can someone get pregnant with low AMH levels and PCOS?
Two separate questions, or yeah.
I was going to say that's a lot packed into one little sentence there. Well, I guess I'll take a stab at it, and Dr. Henningsman, you can fill in if there's things that I don't mention that you think are important. So just to level set. So number one, AMH we mentioned earlier, which is it's a hormone. It's just a blood test. It's a reflection of egg supply, and in general, younger women on average have higher AMH because you start out with more eggs, and older women on average have lower AMH because everybody has a decrease in their egg supply as they get older. But as I said earlier, that's not a foolproof system, meaning there is such a thing as being younger with a lower AMH or older with a higher AMH. It's kind of individualized. So having a low AMH means you have a low egg supply. So that part of the question, let's take it sort of individually. Can you get pregnant with a low AMH? The answer is definitely yes, is the short answer. The long answer is that, and this is actually a very important point, because AMH has become very, very popular, I think for good reason in the last decade or so, but I think it is often misunderstood because I think it's often seen as a marker of fertility or as a fertility test. And that isn't technically totally untrue. It is a test that relates to fertility, but in the sense of a test that can tell you if you are fertile or not, or if you will have a hard time getting pregnant or not, it actually does not say that whatsoever. And the fundamental or the conceptual reason why that's true is because of the following. In the natural setting, if you're trying to get pregnant naturally, you ovulate one egg every month. And that's true whether you have a very high egg supply or a very low egg supply. Everybody ovulates one egg per month. And so actually having a low AMH, or a high AMH for that matter, literally has nothing to do with whether you have an easy time or a hard time getting pregnant. Now, if you're older with a low AMH, which is normal, then if you're having a hard time getting pregnant, it's because you're older, and that relates to egg quality. But the fact that you have a lower egg quantity, again, as long as you're having regular cycles, if you are, doesn't impact your chances of natural fertility at all. So then why should you care about low AMH? Well, basically because your buffer zone is thinner than maybe we'd like it to be. Meaning if you have a low AMH, A, we know that means you're getting closer to running out of eggs. And B, is that if you did need assistance, like in a fertility clinic, like in an IVF cycle, so egg freezing and IVF are both treatments that rely on numbers. People do egg freezing or IVF, they might get 5 eggs or 10 eggs or 15 eggs or 20 eggs. Every egg is a sort of ticket to success or a potential ticket to success. And getting 20 is generally better than getting 5. But having said that, someone gets 5 and someone gets 20. So who gets 5 and who gets 20? Well, the answer is your AMH, your egg supply, is the main driver of that. So having a low AMH means that you have less buffer, because if you did need to talk about egg freezing or IVF, you may not respond as robustly to the medications. You may be someone who only gets, let's say, 5 eggs at a time, and that would potentially impact the prognosis, the chance of success, if you're doing a fancier treatment like that. So that was a very long answer to a very short question. I'll let actually Dr. Henningsman do the PCOS part, because I'm talking too much.
Yeah. And I just want to say, historically, AMH, people are always talking about this. Historically, AMH is exactly what Dr. Klein said. It's how well you're going to respond to IVF or ovarian stimulation. That's basically what we use AMH for. We check it. Women with PCOS have a little bit higher AMH typically, just because they have a lot of immature follicles on their ovary that are producing that AMH. So yeah, we really don't. We put a lot into it, but I don't want women to freak out if their AMH is low, because again, it's really how are you going to respond to fertility treatment is how we use AMH. PCOS, the big issue with PCOS and getting pregnant is ovulation. So a lot of times women with PCOS they have oligomenorrhea, so their periods are a little bit longer, or they have amenorrhea. Once you get them to ovulate, then it's going to be much easier for them to get pregnant. I have patients coming to me that aren't ovulating. I give them metformin, they ovulate, they conceive. So I've had about probably 30 pregnancies in 2.5 years for women who are having problems getting pregnant. So PCOS typically is an issue with ovulation. Once you can get them to ovulate with lifestyle, losing weight, metformin, insulin sensitizers, then your chance of conceiving is going to be better, obviously. So just because you have PCOS does not mean that you're not going to be able to conceive, and just because you have a low AMH does not mean you're going to be able to conceive, in kind of a nutshell answer.
Yep. And I'll just emphasize, as we said earlier, not every patient needs IVF, right? Someone who has PCOS who isn't ovulating regularly can sometimes do things as sort of fundamental to their health as improving their diet, losing some weight, metformin, those kind of medications that aren't traditional fertility drugs, and they can have a decent chance of getting pregnant if they restore the ovulation without doing anything more invasive than that. The other thing I'll say is on the low AMH, I just have a little anecdote. When we first opened our clinic, we had a medical assistant who was in her late 20s, and she had a boyfriend. She wasn't ready to get pregnant. She was on birth control, and all she would hear all day is AMH and egg freezing. And so one day she said, you know what, I'll just check my AMH. And of course she checks it, and it was like 0.2 or something really low, and she totally panicked. And because of that, we talked about it, whatever, but she basically said, you know what, I have this boyfriend, I think we're ready. I'm going to just stop my birth control and try to get pregnant. And like literally she got pregnant the first month she tried. So low AMH does not mean you're low fertility. It's really a separate issue.
Right. I love that. I love the kind of personal, personal success stories that you've seen practices too. I'm sure that is really helpful for people to hear. I know some of this can seem kind of theoretical, but you've both seen, this obviously have a lot of success with your patients and people who are close to you. We did get a question in the chat, which Dr. Henningsman, you did answer. It was just, is PCOS correlated to low AMH? So I think we've covered that. Does anybody, I have allowed you all to unmute. So if you feel brave and you'd like to unmute and ask a question, don't hesitate to do that. We still have a good couple of minutes left, so we can certainly get through any kind of questions that you each have, or feel free to put it in the chat. I will go through another couple here that were submitted ahead of time. I think we have sort of talked through this a bit about nutrition and lifestyle. So let's see here. We did get a few questions about nutrition and diet and vitamin regimen to help with prepping for the egg freezing process and kind of the fertility process, which I know we've talked about that a bit. I know this is probably going to be a more specific kind of question that each of you, anybody here would have to go through with their doctor, but are there any kind of maybe tips or favorite tips that each of you might provide for some, a diet and lifestyle type of plan that you like for patients?
I mean, I like the dietary advice that our RDs give, and it's very much kind of an anti-inflammatory diet, Mediterranean diet, for lack of a better word. So I really like that. And again, I really think it's important to get proper exercise. I think our Western society, we just kind of sit around, and we're not really meant to sit around. And so I think the most important thing, studies have even shown if you lose 10% of your weight, if you're in an obese or overweight range, then that's going to help significantly. So really just getting out, walking, nothing crazy, nothing high intensity. I'm not a huge fan of high intensity. So you just walking for an hour a day, 5 days a week, plus strength training, like reformer Pilates a couple days a week is really, really good. And then really the dietary advice our dietitians give, it's not restrictive whatsoever, but a lot of plant-based with a good amount of protein as well. So just kind of a really healthy diet and exercise program is going to be beneficial for trying to conceive, but also during pregnancy. It's super, super important, and postpartum as well, with postpartum depression, postpartum weight gain, things like that. So yeah, that's kind of the lifestyle. I would recommend, obviously, folic acid if you're trying to get pregnant. It's going to be an important supplement to take. Yeah, that's my recommendations. I don't know if Dr. Klein has any.
Yeah, no, I think that's easy to get on board with, and I would agree with all of that. I mean, and the only other thing I would sort of emphasize is I think moderation mostly rules the day. Whether it comes to diet or exercise, for the most part, anything extreme is usually not the best way to go. So a balanced diet, or developing an exercise program that is not going from 0 to 60 in a short period of time. Is usually going to be a more sustainable, more sort of robust way to kind of achieve the kind of changes that you need to that are sustainable in the long term. So yeah, for the most part, like the quick fixes just don't generally work. And if anything, they can sometimes be problematic. So, stay away from extremes, I guess is the
that's exactly right, because you can't go on some crazy diet and expect that to be sustainable. So it's something you have to be able to incorporate, your entire life. So yeah, that's a good point.
Right. Okay. This is a really good question. And I think this was actually supposed to be part of our presentation. I think we almost went through it a little bit quickly. So I want to take it back to you, Dr. Klein. One of our participants asked if we can actually walk through the egg freezing process.
And yeah, I actually never returned to that.
And that whole thing. So I'll let you kind of take it away with that one.
Yeah. So let's see. I think just to reiterate a tiny bit, to me, the first and most important part is to understand your story, which is to say, again, like, how old am I now? How many kids do I imagine wanting to have? How soon might I be ready to start a family? What is my ovarian reserve? What is my egg supply with regard to AMH, follicle counts? And what is an expected amount of eggs that I might gain out of an egg freezing cycle? Because those are the parameters that we can use to think about how valuable egg freezing might be. Once someone has the opportunity, and just for practical purposes, that's a conversation that usually takes me 45 minutes to an hour with a patient, even though obviously that sounds like a lot, but there's a lot to unpack there. Once the patient decides that egg freezing is a choice that makes sense for them, so there's usually some minimal prep, which is that most programs will need some basic blood work, like HIV testing, hepatitis B, hepatitis C. They call that usually the checklist, and some paperwork that, consent forms and so forth. And then the key piece of prep tends to be the education around the medications, because the medications that are used to get eggs to grow, and this is true for both egg freezing and IVF, are what we call gonadotropins, which are basically hormones that are ordinarily produced kind of near the brain that communicate with the ovaries to allow eggs to grow. But they don't, from a chemical perspective, they aren't, you can't make them into a pill. They don't work as a pill. They have to be injection medications. And so the main medications for an egg freezing cycle are going to be injectable medications. The needles that are required are what we call subcutaneous, which is basically little short needles that just go right under the skin, not some giant thing, but it is something that people need to kind of warm up to and get familiarity with of how to do subcutaneous injections. Once that stuff is taken care of, and by the way, there are other, of course, ways to like get support in terms of whether it's a friend or professional support to help you with injections. But anyway, every program is going to have their own variation on that theme. The actual process of egg freezing typically is about 2 weeks or less. So usually for women who do have a predictable cycle, we start with a menstrual cycle. For women who don't have a predictable cycle, there's ways to deal with that. So that's not a major problem. But for people who do have a predictable cycle, it starts with a cycle. And essentially, we usually will check someone using an ultrasound and a blood test to verify that everything is starting off from a healthy, normal hormonal standpoint. And then typically it's 8 to 12 nights of hormone injections, usually 2 to 3 injections each night. So it's a lot of little needles. And during that time, people are being asked to come in for brief appointments for what we call monitoring, which is ultrasounds and blood work, usually about every other day, plus or minus. So it's usually like 5 or 6 monitoring visits during the time you're taking the injections. And the idea there is that we're trying to give you enough medication to get to maximize your output, right? Like we said before, every egg is a ticket to success. And so if you can get 10, we'd rather get 10 rather than 5. And if you can get 20, you'd rather get 20 within reason. So we want to make sure we're giving the right medicines and enough medicine to maximize the output. We also need to know when the eggs are finished growing, because different people are different, and sometimes it can be done within 7 or 8 days, and sometimes it can take closer to 2 weeks or more. So that's the hard part of the process, is the nightly injections and those monitoring appointments, which is usually about every other day. And then the capstone is that once the eggs are finished growing, we schedule the procedure to remove the eggs. That's called the egg retrieval. That's typically done under anesthesia. So usually it's an anesthesia that would basically put you to sleep. You wouldn't feel anything. You wouldn't remember anything. And the way we take the eggs out of a woman's body is using a very thin, long needle that is advanced transvaginally under ultrasound guidance, meaning there's no cut, there's no incision, there's no stitches, there's no scar. It's not a surgery in that traditional sense. When you wake up, you won't see any injury. It's a needle stick, but it's a needle stick transvaginally. So it wouldn't be fun if you were not sleeping. But people typically take about 45 minutes to an hour to recover, and then they're walking out the door within an hour after the procedure. So that's the nuts and bolts of what an egg freezing cycle looks like. It's about 2 weeks or less, but it is intense, a lot of shots, a lot of visits, and then a procedure under anesthesia to sort of get the eggs out.
Very good. Lots to do in 2 weeks.
Yeah, it's action-packed.
Back 2 weeks. Great. Do you have an estimate, and I'm sure it varies person to person, but part of our participants' question was how many cycles does it take to go through this? And if there's an average, or if you can maybe speak on how often maybe somebody might have to go through this 2-week joy-filled, fun-filled, action-packed ride?
Yeah, no, that's a really important question. And the answer is the following. So like I know at Extend Fertility, our clinic, the average number of cycles that women complete is like 1.4. Now, what does that mean? Well, it means that a lot of women do 1 and a lot of women do 2, and then a few women do more than 2. But if you look at it a little bit more carefully, what it really kind of derives from is the idea that why would a woman do a second cycle or a third cycle, right? Where does that come from? So the answer is that, as I kind of alluded to earlier in this session, the kind of statistical value of a group of frozen eggs is predicated on 2 things. A, how old the eggs are when we take them out. 25-year-old eggs are more likely to lead to a pregnancy than 40-year-old eggs because they're more likely to be healthy. And B, the size of that group. How many eggs did we get? If you have 20 eggs, you're more likely to have success than if you only have 5 eggs. And so if we look at our own patient population, for example, for women who are over 40 freezing eggs, the majority will do at least 2 cycles, because they know that in order to have a good chance of success in the future, they need more eggs to achieve the same statistical confidence, right? So if you're in the quote unquote reproductively older age group, there's a good chance that doing more than 1 cycle is something that you might want to consider, that your doctor might want to talk to you about. If you're in the reproductively younger age group, if you're under 30, the majority of patients can get enough eggs to feel good about it in 1 cycle and be done. And so it really is a direct sort of derivation of how statistically confident do we feel that you have enough eggs to have a good chance for success in the future if you ever do decide to use those eggs in the future. And so that's, I think, the way to think about the likelihood that you might you never need, but might want to do more than 1 cycle at a time.
Yeah, great. I think again that it's very important to know, yeah, how often someone might have to go through this and what our chances are. So
Yeah.
really
Let
good.
me actually say one more thing, because I think it's a brief way to summarize the idea, sorry, which is that the age issue is a double whammy issue, because on average, younger women, they tend to make more eggs at a time, but they tend to need fewer eggs because they're healthier. Whereas women in their late 30s or 40s, they tend to need more eggs, but they tend to get fewer because their egg supply tends to be lower. And so this is why people are always wondering what's the right age. And Dr. Henningsman said 25. There is no magical age, but the point is, the younger you are, the more eggs you're going to get and the more healthy ones you're going to get, and vice versa. So it is something, again, that needs to be individualized, but that's the kind of take home point, the take home theme here.
Hey, thank you so much for such valuable information. We're really very lucky to have such such expertise for this session tonight. Are there any other questions from the audience that anyone would like to go through? We just have a couple of minutes left. So if there are any other questions in the chat, please submit them now. Otherwise, I'm going to ask our experts to kind of begin to wrap up a little bit. I always like to finish with a little bit of some next steps, right? We just spent the past 50 minutes really talking through a lot of information, a lot of kind of the process that you have to go through, what you might need to do to get started on even thinking about your fertility and getting tested and preparing yourself for a fertility journey. So I will have each of our doctors give us just like kind of a quick, what would be kind of your best next step? And you can each speak from your own perspective. Dr. Klein, yours will be kind of more on the actionable side, maybe Dr. Henningsman more on our kind of, pre-egg freezing side, but what can someone do as a next step?
Yeah, so I mean, I think if you have any concerns whatsoever about any of these, your fertility, infertility, anything like that, I think you just need to go see your OBGYN and express your concerns, and then they can really, take it from there. I don't think you should be looking on social media and blogs and things like that. I think it's best to just go to your medical provider and tell them, your concerns, and let them take it from there. And they're going to listen, and they're going to refer to the appropriate place. They'll start the workup, and they'll do everything correctly. So yeah, just go to your medical provider, your OBGYN, and express your concerns would be what I say is the most important thing to do.
Thank you so much.
I mean, I certainly agree with that. And I would say another sort of just fundamental piece is just to try to be honest with yourself about what your goals are. Meaning, again, like family size is a big question, and when you might be ready to start your family, or if you haven't already started it, because the right strategy to get to your goals, of course, is going to be dependent on what your goals really are. And if you don't know, that's okay. But I think clearly about what your priorities might look like, and then also to just get information specifically about your own biology, which is to say, if you're not paying attention to your cycles, like, it can help to know what your cycles do. There are all these apps these days that are easy to work with as far as like tracking your cycles, and at least having some kind of track record. Following 1 month is never going to be super informative. So it does take time to actually get familiar with your cycles if it's not something that you're used to doing. If you want to do some basic testing, whether it's an AMH test or any other basic testing, if you have a boyfriend and if you guys are thinking about it and talking about it, and he just says, you know what, maybe, or maybe you say, just to do a semen analysis. It's an easy test to do. It doesn't cost that much money. It can be done at home. There are companies that arrange for a home semen analysis. Like, there's a lot of information you can get without a gigantic amount of investment. And so if you're trying to strategize for the future, starting to assemble some of the, again, goals and priorities, and also trying to gather some data points to kind of look at what we know and what we don't know, and then try to lean on someone that you trust, whether it's Allara or your OBGYN or whomever, to like help you organize what that strategy should look like. I think it's definitely it's one of those things where chance favors the prepared mind, as they say, like, taking this topic thoughtfully and, I don't know, carefully, it probably will tip the odds in your favor that you're going to get to your goals. So I think to do those kind of things is definitely stuff that can prepare you well for the future.
All right, thank you so much. I think we have a lot of really good actionable steps and definitely some really good information. So hopefully everybody who's here is feeling a bit more educated and a bit more confident about things that you can do to improve your fertility or just understand your fertility better, and definitely some places that you can seek really expert advice from. I'm just going to put a couple of links here for Blooming Eve, if you are interested in checking out the wealth of practitioners that you might find on Blooming Eve that can help you with your second part of your fertility journey. And of course, Allara, if you are already a patient, then fantastic. Take some notes from tonight and bring them over to your next visit with your provider. And if anybody does need help getting set up with an Allara provider, you know where to find us. You will receive a follow-up email with a bunch of links that you can use to get more information about both Blooming Eve and Allara if you are not yet participating with us. All right, so we'll end here for this evening. Thank you once again, Dr. Joshua Klein from representing Blooming Eve, and then Dr. Stacy Henningsman representing Allara Health. Thank you so much for your time tonight.